Good morning. Why don't we go ahead and get started? I know people are trickling in, and so my name is Darshan Mehta. I'm the Associate Director of Education for the Osher Center for Integrative Medicine. We're really delighted to have all of you here today at our Integrative Medicine Grand Rounds. Before I introduce the speakers, I just wanted to highlight a couple of upcoming events. Hopefully that all of you here have already registered for or are planning on attending. So first, this Thursday, we have Dr. Brad Manner speaking at our Integrative Medicine Research Seminar, which is held on Thursday afternoons from 4 to 5 p.m. Here at the Brigham. It's going to be in the Zinner breakout room at the 70 Francis Street. And Dr. Manner is going to be talking about maximizing mind-body connections to minimize balance decline in aging and disease. So it looks to be a really exciting talk, and hopefully you will be able to attend. And then also we're really excited about our upcoming Integrative Medicine Network Forum, which is going to be held at the Joseph B. Martin Conference Center at Harvard Medical School. It's on Friday, November 18th from 8 a.m. to 2 p.m. Registration is free. Lunch is provided. And we would really encourage all of you to register and attend. This is we are at about 300, close to 300 people attending this event. So it's really meant to be a broad representation of integrative medicine activity across the Harvard-affiliated and Boston area hospitals. And our keynote is Dr. Alessio Fasano, who's the Division Chief of Pediatric Gastroenterology and Nutrition at Massachusetts General Hospital. In addition, we're going to have other eminent scholars presenting from our local area as well. So please do attend. There's going to be a presentation of research, presentation of clinical activities that are happening across our system, and really it's a wonderful opportunity to meet all of our colleagues at doing work that some of you may already know of, and hopefully many of you will learn about new work, or maybe you didn't even realize that this work is already happening right next door to you. So, or even within your own institution. So please, again, that's Friday, November 18th, and we look forward to having you attend. The information is on the Osher Center website for registration, and it's very simple. And and there are flyers right out up front here as well. Okay, so with that, it's really my distinct and honor and pleasure to introduce our speakers this morning. Our Integrative Medicine Grand Rounds is entitled Integrative Nursing, an Ever-Evolving Caring Science, and our presenters are the representation of the Integrative Nursing Program at Dana-Farber Cancer Institute, led by Dr. Shanna Hoffman, who's a Program Director for Integrative Nursing at Dana-Farber Cancer Institute. In addition, co-presenters include Carolyn Hayes, who's a Director of Oncology Nursing and Clinical Service at Brigham and Women's Hospital and is Associate Chief Nurse at Dana-Farber Cancer Institute. Paula Koppel, who's a Nurse Consultant and Integrated Health Coach for Dana-Farber Cancer Institute. Catherine Hulme-Freudenberger, who's Oncology Certified Nurse at the Dana-Farber Cancer Institute, and also participated in creating this presentation but is unable to be here this morning, Michele Mittelman, who's the co-founder and CEO of Global Advances in Health and Medicine. So with that, I'll introduce Shanna.
Good morning, everyone. I'm so excited to be here today to talk about Integrative Nursing Program at Dana-Farber and this beloved profession of ours, an ever-evolving caring science in nursing. We have a very esteemed panel of presenters today, of integrative nurses. And I would like to acknowledge that Michele Mittelman was a key part in putting together this presentation today, and regretfully, she was unable to attend. I'd also like to acknowledge one other face that isn't shown up here, Dr. Patty Arcari, who's been incredibly supportive in our integrative nursing program. And Patty Arcari just put together this past August a very interesting OSHA Grand Rounds on the use of Reiki in our healthcare settings, which was a very lovely presentation. So thank you for that, Patty. So we have no conflicts of interest to declare, and we would like to inform those of you who are new to OSHA that you will receive one contact hour for your attendance today, and if you complete your online evaluation. So, of course, we're going to give you a 50-question quiz at the end of the presentation today to make sure that everybody was paying attention for the whole thing, because we know that many of you might be in a sugar coma from last night's festivities. But in all seriousness, these are really the key 3 questions, our learning objectives, that we'd like you all to walk away with today. What is integrative nursing? Why is it important for the well-being of our patients and for our care providers? And how do we support nurses and seed an integrative approach within our care settings? We often use the writing of nursing narratives as a reflective practice for self-care, promoting self-compassion and emotional growth or healing as we contemplate the impact of that caring moment that we had with the patient. So I'm so happy this morning to be able to introduce Catherine Hulme-Freudenberger, who's an outpatient infusion nurse at our DFCI satellite practice. Catherine will graciously be sharing with us this morning a special nursing narrative that she wrote based on her practice.
Good morning. I'm going to start by taking a little of my own advice and take a deep breath, which is the title of my narrative. Take a deep breath. These are words I grew up hearing as my father would calmly guide me through whatever upset was upon me, big or small. He would suggest, take a deep breath, one more time now. Let's see what we've got here. I could never predict from this experience that I would connect so naturally with meditative breathing, but of course it makes sense. I could also never predict that these would be some of the last words I spoke to one of my patients. Colin was diagnosed with esophageal cancer when he was in his late 50s. He underwent standard first-line chemotherapy and surgery and was back to living his full life. Unfortunately, this was again interrupted by recurrence. Upon return to the clinic and to treatment, upon returning to the clinic for treatment, feeling well and with the support of his wife, we began a conversation about palliative care. We had all seen an article in the Boston Globe about palliative care, and this led us to making arrangements for him to be seen in Boston. Milford, as yet, had not established an outpatient palliative care team. I'm happy to say we do have one now. I believe this was one of the most important decisions Colin and his wife made, and gives you a glimpse of the strength and fortitude of this man. The opportunity to reveal his feelings and desires about how the end might look was immeasurable. It provided guidance for both himself and his family, but also for me. During this meeting, Colin clearly stated that although he wanted his wife by his side, doing it together, he did not want his care from his wife Maura to feel nurse-intensive and take away from their husband and wife relationship. This clarification, among others, would come to fruition. One of our other ongoing topics was about exercise, as Colin was a big hiker and a fisherman. Yoga, relaxation, breathwork, or meditation were not on his list of activities. Initially, Colin would politely laugh when I spoke of meditation, look at his wife Maura, who would then look at me and sort of smile. Maura practiced yoga, but didn't, and also supported meditation and became critical for my cause. My belief that stress and anxiety reduction through breath work of almost any kind are paramount to managing the weight of a cancer. It wasn't until Colin lost his ability to play the flute, secondary to paresthesia in his fingertips, that he considered my suggestion of meditation. He had difficulty with a keyboard, but he could hold a pen, so we reviewed daily writing or journaling. This seemed to be a form of meditation that Colin felt he could connect to and realize the benefit. I also asked Colin if listening to the music he created would bring sadness or perhaps comfort. He thought comfort, as we did have a goal of getting him to play again. So we talked about taking some time each day to just listen and breathe. With the company of his wife, he did so, and without even knowing, perhaps he began to meditate. The practice of breath, connecting body and mind, gives way to an increasingly peaceful, open perspective, and this is a gift that's ever present to us all. So looking back, I guess I could mark the beginning of the end to late in the day on a Friday afternoon in January. I was working an extra shift that week, and it was already past my time to leave. Colin had come in as a follow-up to a scary episode of respiratory distress resulting in a thoracentesis. We were checking labs and hydrating that afternoon. So as I mentioned, I was aware of our palliative care discussions and the meetings in Boston, and I knew we were missing something. So after getting things started, I entered the room with the MOLS form in hand. My intention was to introduce the form and suggest that they take it home over the weekend to discuss, and then return on Monday for us to complete with their oncologist. I presented it as an extension of our past conversations for palliative care, as well as connecting it to this most recent respiratory crisis event. They both agreed it was a good idea, but they wanted to do it right then. I took a deep breath, had a quiet moment, and I took a seat. Down the form we went, as if checking off grocery items. Intubation, ventilation, chest compressions, and on. All treatments met with an unwavering no. End-of-life hydration, however, was a stumbling block. Colin voicing a clear no thank you. Maura voicing a different opinion. Why wouldn't hydration keep Colin alive so our daughter will have time to say goodbye? She lived across the country. Colin asked, keeping a person alive just so someone can say goodbye? That doesn't seem right. I found myself then in the middle when they asked my opinion. What is the purpose of IV hydration for a dying person? Another deep breath, another pause. These questions were enormous. I looked at Colin and then to Maura, sensing the heaviness of the moment. I truly did not feel I could give them the answer beyond the basic biology. I could understand both sides. One, a nurse advocating for her patient's wishes versus a mother and a wife advocating for the gift of their child saying goodbye. I called our oncologist to assist in the review and to guide this decision. And in the end, they were able to agree on IV hydration short term. This decision, again, would come back to us. Coincidentally, about the same time, Colin and Maura announced the engagement of their daughter. This was, of course, wonderful and frightening. Would Colin make the wedding? Within 2 weeks, a beautiful wedding was planned with every traditional detail in place, and our goal quickly became getting Colin to the wedding. Treatments, symptom management were all looked at carefully, trying to gauge any and all possible side effects. Unfortunately, on the Monday prior to the wedding, we had to send Colin into the Boston hospital in respiratory distress related to an increased mass that was found in his right lung. Upon further evaluation, it was discovered that Colin had developed a fistula between his esophagus and right lung, as well as esophageal varices. NPO, IV antibiotics, and IV hydration, pain management, and anxiety management were the focus of care that week. Maura kept me updated from Boston, as by this time we had exchanged cell phones. I had been invited to the wedding and had let the family know already that I was available as a guest or as the nurse. When I woke the Friday prior to the wedding, the sun was shining, and although it was brisk, the forecast for the weekend was sunny and bright. I felt like we had made it. Colin had made it. I was just over the bridge into Newport picking my daughter up for her spring break when my cell phone rang, and it was Maura. She called with an update and to tell me that a visiting nurse would be coming to the wedding specifically for Colin. She wanted me to know about the nurse because she did not want me to feel awkward as if they were replacing me. I assured her that I only wanted what was easiest and best for Colin, and that again I would help in any way they wanted. There was a pause, and it occurred to me that maybe Maura was calling to see, or hoping perhaps, that I would be that nurse. I took a deep breath and asked Maura, stating, "You already have everything arranged, so I don't want to create more work, but would you like me to be the nurse on duty for the wedding and the reception?" And she responded, "Yes. We know you so well and feel so comfortable with you. We just did not want you to feel obligated." Of course, I was honored, would never feel like an obligation. We said goodbye. I dried my tears, picked my own daughter up, and drove home grateful for my own life. To be continued.
So nobody in their right mind follows things like that, but I'm not particularly in my right mind. I am, as introduced, the Associate Chief for Oncology, Medical, and Integrative Nursing. And having Integrative Nursing in my title is a blessing and a curse, because I am someone who believes that that is a, at best, redundant term. And I've said that to the people, Kreitzer and Kothan, who have authored the book entitled Integrative Nursing. And so let me tell you a little bit about the history of that book in particular. As Andrew Weil was writing integrative medicine, then there was integrative PT, and there was integrative social work and integrative nutrition, and all of these books were appearing. He asked Mary Jo Kreitzer, who leads the University of Minnesota Center for Spirituality and Healing, to write the book on integrative nursing. And she said, "I'm in a bit of a pickle, because what we espouse in this thinking is actually just nursing. That nursing has always had a holistic practice and always valued these things." So what she agreed to do was to connect with international and national nursing thought leaders and say, "Okay, drill it down for me. What are the principles that guide nursing practice? How would you describe that?" And that is what became how we define these 6 principles of integrative nursing. Human beings are whole systems inseparable from their environments. Human beings have the innate capacity for health and well-being. Nature has healing and restorative properties that contribute to health and well-being. Integrative nursing is person-centered and relationship-based. Integrative nursing is informed by evidence and uses the full range of therapeutic modalities to support and augment the healing process, moving from least invasive to more, depending on the need and context. And integrative nursing focuses on the health and well-being of caregivers as well as those they serve. So if you look at bullet number 5, what gets confusing as I traverse the universe is everyone assumes what I'm automatically talking about are integrative therapies. So trying to explain that, yes, we do use least invasive to most invasive. We absolutely believe these things are evidence, we check on the evidence, and we believe that they are of benefit to our patients. We also think that that is in the context of a relationship, and that is knowing that the patient themselves has the ability to heal, and that nature and the environment matter, all of which, and in the last bullet, I have to say, integrative nursing focuses on the health and well-being of caregivers as well as those they serve. That has not always been something that our discipline has done particularly well. I know that in my primary education as an undergrad, I was basically told to suppress my feelings, and he thought that I was actually Carolyn Hayes and walk in the room. And of course, what becomes perfectly clear is you can't have relationship-based care if you don't acknowledge there's somebody to have a relationship with. So that is a work in progress for our discipline, but we are, thank goodness, working on it. So integrative nursing, being, knowing, doing. It really is not what I do, but who I am doing this. Janet Quinn is out at the University of Colorado, known in extensive writings and research for Reiki. And what she said was, these strategies have been part of regular expert nursing care since the time of Nightingale. And I actually have 2 separate 1-hour-long lectures tying extensive quotes that Nightingale said about things like pet therapy, music therapy, light therapy. And of course, Nightingale back with the lamp was in the Crimean War. So these are things that she would talk about trancing the patient, for example, and we would call it guided imagery. She talked about how important movement was. She talked about nature, light, and she talked a lot about the nurse. And in her case, they were all women. The patients were all men, and the nurses were all women. So she had no pronoun problems, having written during a time of war. But she said, health is not only to be well, but to use well every power we have. And that's an important thing for both the nurse and the patient. So think about it. From the patient's perspective, it's not just enough that we are trying to physiologically intervene, but we are also trying to keep them whole. And what powers do they have? So what could Colin control with its positive without the negative connotations? How do we maintain agency and dignity even if the body is failing? These are concepts that are that old, and they are the important work that we're to go about and do. It's also true of the nurse, that it is not just the techne, it is not just the fluids, it's not the IV, it's not the medication, it is actually your presence. And so a lot of integrative nursing work focuses on what is the presence and how does the patient feel known. And Nightingale was big on talking about curing. So this is 1860, just to frame it. It is often thought that medicine is a curative process. It is no such thing. She's a very tough lady. Medicine is the surgery of functions, as surgery proper is that of limbs and organs. Neither can do anything but remove obstructions. Neither can cure. Nature alone cures. And what she's doing in this statement, and this is from Notes on Nursing, is setting the nurse out to say, yes, we do surgery and we take away problems. We give medicine and we stop bad processes from happening. But still look to the patient. The patient has that innate capacity to heal. Nature alone is healing. Work with the person in front of you. Do the surgery. Take the medications. But make sure you're focusing on the whole person. I'll turn it over.
So I get to do the fun part of the presentation. I get to talk about the evidence and to look a little bit into the research and what it says about integrative nursing and our practice. So an integrative approach is embedded into the foundations of our nursing practice. But what evidence is there to show its value beyond the wholeness that we feel when we practice in this way? There certainly is a growing body of evidence about the use of integrative therapies by nurses in daily practice. Catherine used several of these therapies with her patient: guided imagery, mindful breathing, music, journaling. However, we see within integrative nursing, we see these integrative therapies as a vehicle, another tool in the nurse's extensive toolbox to create presence, caring, a healing relationship. So really, the heart of the matter, the heart of our presentation today, is to talk about what the evidence describes, how the evidence describes the impact of presence and caring within our relationships with patients, in our clinical settings, and within our larger institutions. So as the concept analysis was done in nursing on both the words presence and caring, and these concepts, what concepts do they represent? A qualitative meta-analysis of the literature between 1982 and 2006 revealed that these terms comprise an intentional therapeutic process. These terms, presence and caring, are synonymous in nature and describe substantively similar processes. For the purposes of the rest of our discussion today, we'll refer to these as the caring process. So based on the meta-analysis, this schema was created to illustrate the caring process. there are antecedents, and we know this kind of logically, we know this from our experience of practice, but the literature is able to sort of describe it a little bit more clearly for us. So we know that there are antecedents, there are parts of the care relationship that need to happen before in order to support this caring process. Those antecedents occur both in the recipient and then in the nurse. There are attributes that describe this process and allow us to recognize it for what it is: an intentional therapeutic process, expert nursing care, intimate interpersonal sensitivity. And then there are outcomes that result from this caring process that occur both in the recipient and in the caregiver. So I just want to take a minute to kind of reflect back on the beginning of Catherine's story. She says that it wasn't really until Colin lost his ability to play his musical instrument that he really considered meditation. Now that's sort of an example of the patient's openness and needs, care needs, that showed up during the caring process. She also writes that he said to her, I don't want my care for my wife to feel nurse intensive and to take away from our husband and wife relationship. Again, that's sort of an example of maturity and personal and professional maturity, and Catherine's ability to recognize that and work with that also showed her expert nursing practice and intimate interpersonal sensitivity. When Maura, the wife, called Catherine and said, "We have everything in order," Catherine took a moment, took a deep breath, and thought about it and said, maybe she's calling to find out if I'll be that nurse. I think that's a great example of how her expert assessment of the situation and her acute interpersonal sensitivity allowed her, that caring process, to flourish through that interaction. So what are the outcomes of these intentional therapeutic relationships or processes? A systematic review of 13 randomized controlled trials showed improvement in both physical and emotional outcomes. The studies showed reductions in pain, blood pressure, body weight, psychosocial disturbances, including anxiety and depression. The majorities of the studies focused on the MD-patient relationship. But in 3 of the studies, they also looked at the relationships of the RNs, the NPs, and the PAs. Lastly, I'd like to point out that this study was unique in that it excluded studies using intermediate outcomes, such as patient satisfaction, comprehension of treatment, and adherence to the treatment plan. Although we know that these intermediate measures are mediators of health, it's important to make the distinction regarding the direct efficacy of the caring process and some of the measurements that matter most to our patients, which aren't really patient satisfaction and adherence and comprehension. So just a quick word here on the interdisciplinary research and evidence. The impact of the caring relationship is very well documented in the psychological, spiritual, and literary evidence. But interestingly, I'd like to point out an emerging area of research lies in the BIDMC and Harvard Medical School program and placebo studies. They write, for many years, the placebo effect was considered to be no more than a nuisance variable that needed to be controlled in clinical trials. Only recently have researchers redefined it as a key to understanding the healing that arises from medical ritual, the context of treatment, the patient-provider relationship, and the power of imagination, trust, and hope. Further description of these phenomenon could further clarify, perhaps, around the mechanism of action and impact of this caring process on our outcomes. Outcomes as currently described in the literature by patients and nurses include diminished pain, enhanced comfort, increased self-care, decreased stress, and enhanced capacity to cope, greater self-esteem, revitalization, sense of mental well-being, and peaceful death. So how do we support nurses in this caring process and make this relationship-based approach to care as reliable and consistent as our chemotherapy administration? So our program in integrative nursing is a multi-pronged approach that happens on 3 levels. The nurse individual level, the nursing unit or interdisciplinary team level, and then within the larger system or institutional level. Our trainings in integrative therapies, as Carolyn so eloquently illustrated, it's not all about the integrative therapies. But our trainings on integrative therapies include mindfulness, Reiki, and acupressure. And these give individual nurses some of the tools to increase their confidence in building trust and presence with patients. More importantly, these nurse-focused trainings help nurses to gain the comfort and the language to describe the importance of the caring process and to create space within his or her practice to approach holistic health in every teaching and coaching interaction with patients. This language and space, as we heard from Catherine's narrative, is really vital for the caring process to occur and for this relationship-based care approach to be sustainable within any care setting. Our practice grants and design thinking programs are examples of ways to take an integrative approach into the unit level. And these programs help to bring validation to the nurses' time spent on relationship building and inspire nurses in their caring relationships with patients, which connects us deeply to our own practice and also to each other on our teams. The Integrative Nursing Consortium of Boston and the Research Fellowship are programs that help support the sharing and building on the evidence that informs our practice across institutional walls. These programs also help to elevate nursing at the institutional level. So what are these institutional outcomes that we look at to measure the caring process or determine its value to the system? Within the research evidence, we see that nursing practice environments conducive to the caring process are associated with improved intermediate outcomes such as hospital performance and patient safety, reduced burnout, compassion fatigue, and increased patient satisfaction. But these measurements still struggle to quantify the cause and effect of caring. So our ability to provide what patients want and need most, that caring relationship, may require that we ask questions that look more like these. Their answers will better reflect our ability to provide relationship-based care and healing, and may be the key to reframing the value system in which we provide care to better represent the contribution of an integrative approach. Prevalent notions of evidence-based knowledge based chiefly in a post-positivistic quantitative perspective are too restrictive for nursing's multiple ways of knowing and limit what gets recognized as nursing knowledge, and therefore may also limit what is seen as our contribution to the care of society. So these are our conclusions from looking at the evidence. A human-centric, relationship-based approach that integrates the art and the science of caring is important for the well-being of not only our patients, but for us as care providers. Nursing represents an ancient and sacred covenant based upon integrative principles, and that when each discipline contributes their unique way of knowing and being to the team, we can transform care within a holistic approach. We'll now ask Catherine to come up and finish reading her narrative and to share the outcomes of this special caring process that she had with this family.
Excuse me. So, one more phone call from Maura brought me to the Boston Hospital Saturday morning wedding day to receive and manage the medical equipment and medications from the home care company. Seeing Colin in a hospital bed, pale, hair askew, hospital Johnny draped over bent forward shoulders with O2 misting up from a face mask, the raspy gurgle of the wall suction in the background was a shock. I did my best to hide my surprise and my heartbreak. Colin lifted his eyes and said to me, "Man, this is weird." Like, "Yep," I answered, "not our usual gig, is it?" "Are you doing any better?" I asked. "Maura told me that you had been having some breathing difficulty the past few days." "It's been a rough morning," he replied, "but I seem to be doing better." "Alrighty, may I look around and speak to your nurse?" So report given, I then met with the home care team to review the pump, IV fluids, and antibiotics that I would be administering. During our conversation, however, I noticed Colin becoming increasingly anxious. I stopped my tutorial when he frantically spoke, "This feels different, I can't breathe." Pushing a call light, I directed him to look up at me. Eyes connected. "Your O2 sat is normal, Colin. Are you getting air?" "Yes," he said, "but it feels harder." "Okay," I responded. "Try to take in a slower breath. In through your nose, gently out through your mouth." He had heard this coaching from me before. His hospital nurse came in with morphine. I asked for some Ativan, and then after a few minutes with quieter breathing, fear melting away from Colin's face, he whispered, "I'm not sure I can go." I suggested we give it some time, but I assured him that I would stay with him until he was ready. We would either go to the church or meet everyone at the reception if he needed more time to feel confident. I wondered out loud if all the directions and tutorial that had been going on became overwhelming for him, but I assured him it was all on me. All you have to focus on today is being father of the bride. He smiled, looked up at the clock, and reminded me he'd better start getting dressed in his tux as Maura would be there soon to pick him up. We agreed that I would have his hospital nurse come in to get him started, and that when he was dressed, I would come back in. Maintaining his dignity and our particular nurse-outpatient relationship was extremely important. I was invited back in to help figure out those decorative tux buttons that fit over the regular ones. It took a few minutes, but we got it. As I started to complete the first button for him, he reached up to do it himself. Yet another reminder for me of the importance of maintaining patient independence. So I sat down on the stool and handed Colin the tiny buttons and watched while with numb fingertips he diligently worked until all the buttons were in place. He then snapped on his suspenders, slipped on his jacket, and stood up slowly, adjusting his shirt. Maura then entered the hospital room in a beautiful royal gown, meeting and holding Colin's gaze. Seemingly unaware that the hospital nurse and I were still in the room, I handed Maura the bow tie and told them we would wait in the hall until they were ready. And a number of moments later, the door opened, tie in place, they were ready to go. Once at the church, I took my seat in the front after checking on the O2 and obtaining pain medication for safekeeping. The music began, and through tear-filled eyes, I looked on as Colin and Maura accompanied their only child down the aisle to begin a new life. There was joy and love and family. There was no cancer in those moments. This is always the hard part. No shortness of breath, no need for oxygen, no IV fluids, weakness, or fatigue, only joy. Colin danced with his daughter at the reception, posed for pictures with family and guests, and spent the time talking and laughing with all. And although I was seated at his table, I did not want my physical presence to be a constant reminder of his illness, so we worked out a plan. I would not spend the night staring at him. He would give me a thumbs up or a thumbs down as needed. So it was about 9 o'clock when I noticed Colin pushing himself slowly back from the table. I held my gaze out the corner of my eyes as he reached for his cane and stood up. I waited and watched, and he was quickly met by Maura, and they walked over to the next table just to visit. Again, independence, dignity, and grace. Not too long after this, however, I glanced up from my conversation, and he gave me a thumbs down. Colin, Maura, and I slowly left the room. The hotel had graciously provided a lovely suite across the hall from the banquet room to which we went. It had been Maura's wish that should Colin become fatigued at any part during the evening, he would be able to rest and still be visited by family and friends. I helped him get comfortable in an overstuffed chair, resumed his oxygen, started some fluids, and left him surrounded by family, collar open, tux tie hanging loose around his neck, with an expression of completeness and accomplishment, peace on his face. He was the father of the bride, basking in these precious moments with family and friends and his lovely wife at his side. His wish, as well as hers, was then to spend this beautiful night together. Early the next morning, I sat in my favorite coffee shop, sipping my favorite mocha and taking in the Boston energy. The sun was out and the air crisp and cool, and Colin had achieved his goal. Independently, with dignity, arm in arm, he guided his daughter safely to the threshold of her new married life. And then my cell phone rang. It was Maura. "I think you should come, Catherine. His breathing seems more difficult. His feet are also starting to swell." Remembering the mole's form and the wishes Colin had expressed to his palliative care team, I was able to answer no when asked if we needed to continue the fluids, run the IV antibiotics. "We'd like to go home now," Maura expressed. In the end, an ambulance became necessary as Colin's condition worsened that morning. While arrangements were being organized for his transport, Colin was visited by his siblings surrounding his bed as if they were meeting for coffee. It was beautiful to see. He spent some time with Maura and his daughter as I packed up the medical equipment to be sent home. The ambulance arrived. Colin stood up out of the hospital bed in the hotel room and, using his cane, lowered himself into the ambulance chair for transport to the hospital. A quick synopsis of the situation was reported by me, oxygen reapplied, DNR located, and then I had to decline Maura's request for me to ride in the ambulance with Colin, my own family duties calling. That was incredibly difficult, and I felt a sudden loss. The driver then tipped the ambulance chair back and started to push Colin away. "Wait," I yelled, and I stepped in front of the chair. I took a deep breath. I looked in his eyes. Another deep breath, connected, trusted, and whispered, "Take a deep breath, my friend. Just one breath at a time." And looking back at me, he nodded, briefly smiled a crooked smile like he did every time I mentioned meditation breathing. "Love you, Colin. Love you too, Catherine." And that would be our last exchange. Maura called me later that night to inform me of what I already knew. She told me that once home, Colin had walked himself into the house from the ambulance, again refusing any assistance. He sat down in his favorite place on the couch, embraced by Maura on one side and his daughter on the other. After a time of visiting, they just sat, Maura told me, quietly, just the three of them, and soon Colin slowly stopped breathing. He was surrounded by love, all of them surrendering, not to death, but to this moment with open, peaceful, and accepting hearts. I cannot express in words entirely the depth of meaning this experience has had for me. The connection, the trust, the witnessing of the power of this family's love, the intimacy of the weekend was profound. It could never have happened in this way if this family did not trust me, and for this I am honored and eternally grateful. I believe trust to be the most important characteristic of any relationship, and I strive to make it the foundation of my practice as a caregiver and as a healer. I believe that it grows over time when we are present for one another. It happens when I take the time to deeply listen, to be present with myself and for my patients. When I focus on my breath, even for just a moment, I slow down. I awaken to the moment and all that is in it. I pay no attention to the man behind the curtain, as Oz proclaimed. I pay attention to what is in front of me. This trust then gives over to the gift of connection with my patient, this human being in front of me who is in a most vulnerable place, for whom I am charged with caring. Only then am I able to meet them where they are. Thank you.
I'd like to take a moment to share Maura's reflection, Colin's wife. She's unable to be with us today. She says, "I'm sorry that I'm not able to be with you in person today. I appreciate that the team is here willing to share my thoughts and reflections on this caring moment. We began this journey as any new patient and his wife, vulnerable, shocked, scared, and hopeful. Our close and trusting relationships were built over time through innumerable small interactions that culminated in sharing intimately the joys and sorrows of Colin's final days. My husband's experience of care and my experience of care were inextricably linked with our relationships with Catherine. Catherine was our guide on a journey that we never anticipated and certainly did not wish to take. She was by our side from the beginning, helping us to navigate the logistical and emotional ups and downs, the challenges and the hopes of initial intensive treatment, the comfort and dreams of a year during which treatment appeared successful, and then our devastation when Colin's cancer reoccurred. She was there for us to lean on when we re-entered treatment, providing understanding and emotional support as our focus shifted to quality of life, palliative care, and end-of-life wishes. Catherine was truly present in all our interactions, listening deeply and with empathy and respect to both what was said and what was unsaid. She asked astute questions which gave us openings to share what we may not have otherwise mentioned, seeking to understand what was important to each of us, getting to know us in a holistic manner, as individuals in our relationship together as husband and wife, and as a family with our daughter. Our experience of care felt personalized, coordinated, and aligned with our values. Colin felt he was understood and respected, valued, and cared for as the wonderful and multifaceted man he was. Cancer was in his body, but he was not cancer. He trusted Catherine completely. She honored and supported the deep husband and wife relationship Colin and I shared, helping us travel this final journey together, thoughtfully, mindfully, and on our own terms, in accordance with our priorities and the deep love, with no regrets. This has in turn helped me to travel this next journey of grief and healing with peace, love, and gratitude in my heart. I think of Colin every day. I miss Colin deeply every day. And I'm learning to live with Colin close in my heart rather than physically beside me. To find peace and joy in the small beauties of my life, a quiet walk in the woods or on the beach, a hummingbird fluttering nearby as I work in my garden, a luminous full moon or a brilliant sunset, the company of family and friends. Catherine accompanied us on this journey, the journey we did not wish to take, but that we took together, making it the best it could be, full of love and no regrets. This has been a gift beyond measure. Thank you. That concludes our narrative and our discussion of the Integrative Nursing Program and process. We'd like to take a few minutes to answer some questions, and our panelists can come up here to the front. Thank you. Pretty close to our time.
Thank you, the team here, for a really moving and wonderful presentation. I think many of us are just sort of just taking it in. But I wanted to, just if anyone had any questions. from the audience. Yeah.
You talk about skills that are foundational to integrative nursing, some very concrete things like mindfulness and how do you cultivate a capacity for presence and caring? By the way, it's wonderful presentation.
So the question, just so everyone hears, is how do you cultivate the capacity for presence?
Well, I'd like to say that I think we all sort of believe that that starts with self-compassion. And I think it starts with recognizing ourselves as individuals in that caring relationship with patients. I think that's really the key where it begins.
And I think, Barbara, when I receive narratives from NLNs, so newly licensed nurses who are just entering practice, and they tell in those narrative stories basically as witnesses, because it's not as much about their practice as what they're seeing. And you can hear their reflections on that. And so I think that, at some point in time when you make the choice to enter into this discipline, there's something there that then it's our responsibility, and I say that as a nurse executive, to make sure that the environment is such that that can be nurtured, that can exist. And so there are things you hear all the time about time. You hear about, all the technology that gets in the way. So what are the conditions of support that need to be in place to allow what might be innate and desirables? Because when people are allowed to practice the way Catherine was allowed to practice, and certainly you as a palliative care nurse practitioner have stories and narratives to share as well. When you're allowed to practice that way, what comes back to you is just as important as what you've sent out, and it becomes a self-fulfilling, perpetual, it feeds itself, if you will. So how do you start there? How do you recognize it and nurture it, and in my case, allow it to happen? And then it takes a life of its own, because really that's what we go into doing. And when we're able to do it, it's absolutely self-nourishing.
I was just going to add too, with a more pragmatic view, that we have made the organization at Dana-Farber has made some significant investments in how can we teach, actually giving nurses an opportunity to learn the skill of mindfulness and explore their own ability to cultivate the mind-body connection. So we've invested a lot of time and resources into giving our nurses the opportunity to learn and cultivate these skills. And it's not just the opportunity to learn and cultivate them, but the investment in those resources and giving nurses the time to go to those programs shows that the organization values that. And we also have people from all levels of the organization participating in those programs. So last January, for example, we had a retreat on a Saturday morning. We weren't sure how many people would show up, and we had 30 nurses at Dana-Farber from all levels of the organization, starting with the vice president of nursing there to look at how do we mindfulness-based practices and practicing and cultivating those skills together. So,
and we had weathermen threatening snow.
Yeah.
So.
I have one more thing to add, just at the really concrete level. I know one of the floors and the Boston campus did a little trial period where the nurses were actually instructed to, or encouraged to sit down and ask their patient, what's the most important thing for you today? So just giving those kinds of suggestions can help a nurse realize that sitting down on that stool instead of standing up, typing in all the patient answers in the computer will really open things up. So that's just I know that the nurses on the floor found hugely successful, and that at Nurse Council we've tried to, spread it institution-wide.
Michele.
I'll just sort of add, there's a wonderful essay by
Ron Epstein from the University of Rochester, JAMA 1999, on mindful practice and how bringing mindfulness into one's clinical practice can improve presence and can improve the quality of care. It's a great essay.
So I want to ask maybe a question for another entire Grand Rounds, but I'll ask it anyways. Physicians, are sort of new to this concept, and part of it has been a recognition around the tremendous experience of burnout that has been widely described across all, in much of sort of the physician, when we look at physician and physician education literature, but certainly has been recognized amidst, as I've had sort of public and private conversations with leadership across all the hospitals here, is a tremendous problem. And I sense, and having spoken to some of the chief nursing officers as well, it's a problem that also exists amongst the. So I'm curious, because where have we missed it? If the education has prepared this sort of a way to sort of keep ourselves whole, has there been some gap that still we haven't addressed? And where is that gap? Where are we missing it? And for physicians, it's a new game, so it's like, oh, I can look at everything because we never had discussed this, and now we're deciding. But maybe you had, and is there a lesson to be learned that we've missed?
So we have, in the literature, nursing literature, tried to avoid burnout and changed it to compassion fatigue. No more desirable a term in my mind. But move towards, when we keep hearing about the triple aim, the triple aim, the triple aim, and people now are articulating the quadruple aim, which the last of which is joy in your practice. It's actually the ABIMF foundation that has put out, because they were concerned about PCPs and how we're losing family practitioners, and that group, is not being replaced by itself because of all of the external demands and the regulatory and what you went into it for. And so that group, the Board of Internal Medicine, really had to take a look at it. So talking about what brings joy into your practice, and it actually is the relationship with the patient. It's feeling that your work is what you intended it to do. So nursing has taken this on and said, okay, what does staff engagement look like? What is joy in our practice? And that's when I say we have to clear the things that are getting in the way of that. Now we have to respond to regulatory bodies, and the first three hits off of the triple aim are about, efficiency and cost and outcomes. But there is this fourth piece, and the patients, what are the outcomes? And so you have to look closely at the patient satisfaction in that as an outcome, and that's relationship-based. So really looking at, and, I'm happy in the circles that I hang out with that I hear about staff engagement, that I'm hearing about, well, what is it that's going on? Because there's this concept in occupational health called backstage, or if you think about Disney World, which I was just at, highly recommend, where, if I'm above ground, I have to be Pluto. I can't break character. I'm Pluto, I'm Pluto, I'm Pluto. Well, enough kids come up and kick you or throw ice cream at you inadvertently. You don't really want to be Pluto. You want to just be like, are you kidding me? You have to go below ground at Disney World to say, are you kidding me? I would argue that one of the problems we have, particularly in acute care settings, is that we don't have any backstage. So you spend all day, whether you're a physician, a nurse, a physical therapist, a social worker, in constant states of bombardment. People are coming at you, and it's problem after problem after problem. And you don't get to be human anywhere. There's no backstage. There's no deep breath unless you find a way to do it. So popping up right outside this door are rooms where you can go in and meditate for a minute. You can take a deep breath. You can just shut out the world. A new recognition of the fact that it's not just, I say about healthcare all the time, a lot of incredibly wonderful people who want to do good in the world. And we wake up and we get into work and somehow it all goes south from there. how. So it's not about who we are. It's not about our intention. It really is about we have at some point, either consciously or unconsciously, chosen to throw ourselves in the path of human suffering. And in that comes principle number 6. You got to take care of yourself. You have to put your oxygen mask on first. Because if I'm not my highest and best, I can't give you my highest and best. So making room for that is really critical to achieving the other parts of the triple aim. So I'm trying to make the business case for self-care.
Great. So on that note, again, we want to give a really wonderful round of applause for our presenters here. Thank you for your presentation.